to implementing a pilot of the Health Equity Ambassadors program. I actually like things that are very concrete. And so I feel like I would like to see us achieve that short-term, relatively speaking, short-term goal.
Absolutely.
Well, hello everybody. My name is Walter Saba. I work with Maryland Latinos Unidos, and we have been collaborating with the PG County Health Department for at least a couple of years, if not three, and mostly in COVID prevention programs during the really bad times, and health literacy. And currently, we are involved in referring people to the telehealth programs via our community health workers.
Welcome.
Thank you. Thank you very much.
I know I look forward to a lot of what you all have already shared, but also ensuring that there are diverse voices at this table, and that more people understand what health equity is, and that it is not just something that's seated um, in the health department. And in terms of the nod to Sharon, I think the concrete way to do that is probably through piloting our Health Equity Champions program.
Hi, everyone. My name is Devlin Jackson. I am representing the Maryland Health Consumer Hub, or Health Information Consumer Hub, sponsored and being led by the Center for Health Literacy in the School of Public Health at the University of Maryland. And I would say that our goal is to ensure that all of the state of Maryland and the counties within are striving towards a goal where every consumer has equitable access to health information and information related to their health. And then also organizations determining strategies and methods to ensure that that is possible for the clients that they serve.
Absolutely. The presentation that we have today will certainly fall in line with that goal. So stay tuned.
Wonderful.
Hello, everyone. I don't know if I can still go or I'm a little bit too late.
Absolutely. Go ahead.
My name is Tamia Shie. I am representing Luminous Health. I am the Director for Community Health Improvement. And one of the things that I am looking forward to in 2024 is to improve our presence within the community to address issues as related to access and health equity, but also to be able to partner with most of you guys on this call to see how we can work together in order to address those issues. So that's what I'm looking forward to in 2024.
Great. Thank you. Welcome. I think we have time for one more, either verbally or in the chat. That's fine. Going once, going twice. Okay, we'll go ahead and move on. So thank you everyone for that. At this time, I'd like to announce our co-chair. So at the end of last year, we did not have a co-chair, and Christine Stewart, who has been with our Health Equity Work Group for quite some time. Christine, can you unmute and let us know how long you've been with us?
I don't know. I want to say 2018, probably closer to if that's when the work group started. It was around the start. So I've been around for several co-chairs. Um, and the big shoes to fill. Like I remember, Sharon Zaliski, who's still with us. Thank you so much. I'll be tapping you for your insight. Phyllis is our most recent co-chair, Sherry Curtis, Stacy Little. So they're big shoes to fill, but I'm excited to support the county I live in, not just work in, but mostly I'm here as a resident who cares.
Thank you so much. Yes, I share those same sentiments. I think I started about that same time as well. So I'd love to introduce Christine Stewart to all of you. So Christine has more than 20 years of experience in public health, and she has worked in various capacities. Ms. Stewart is currently a senior program manager with the Institute for Public Health Innovation, where she has been employed since 2013. While at IPHI, Christine has worked with governmental partners such as the DC Department of Health, DC Health Benefit Exchange, Virginia Department of Health, Fairfax County Health Department, and Prince George's County Health Department. Ms. Stewart has provided backbone support for cross-sector coalitions, has managed the implementation of IPHI Community Health Worker initiatives, and coordinated emergency response team training in Fairfax County, Virginia. Over the last 3 years, Ms. Stewart has been a part of IPHI's Health Equity Training and Technical Assistance Team. In 2022, she has served as the co-chair for the Prince George's County Healthcare Action Coalition, Health in All Policies, HIAP subcommittee of the Health Equity Workgroup. Christine has earned a Bachelor of Science in Community Health Education from the University of Maryland and a Master of Public Health and Health Policy from George Washington University. She has been a resident of Prince George's County for the past 15 years and enjoys spending time with friends and family in her spare time. So I'd like to unmute and welcome Christine very much. Thank you so much for joining us as our new co-chair for the Health Equity Workgroup.
Thank you. And I didn't know you were going to read that out loud. Thank you. I look forward to working with all of you, and especially you, Cesar, and Kim and Taylor, who have been so supportive. And I know you've been through a lot of changes, and I hope to support this work group as best as possible. And I look forward to making some of the dreams that you've all listed as your visions for 2024 a reality together with Cesar.
Thank you so much, Christine. I'll go ahead and turn it over to Kim. She will be presenting our goals and objectives, a refresher.
Yes, thank you. Thank you both. We're lucky to have such wonderful co-chairs. So we'll just quickly go through the goals, objectives, and strategies that we've all discussed. There might be some minor tweaks based on feedback that we've received, but this will serve mainly as a refresher, and this will guide us into the discussion that we have today. So our two goals for the Health Equity Workgroup are to promote the implementation of health in all policies and to enhance the accessibility and inclusivity of public health messages across communities. So within our first goal, we have our first objective is by December 2024, align the goals of the Coalition Health Equity Workgroup with the County Council and Board of Health priorities. Underneath of that objective, our strategies are by March 2024, develop a written process for the coalition to engage County Council and the Board of Health, develop a training and orientation presentation informed by the RAND report recommendations for County Council Board of Health on health in all policies. And then by December 2024, develop a process for the Board of Health orientation as new members are elected. So just to give a quick summary of our discussion from last month or the last 2 months, I think we skipped December. We just mentioned that we needed a better process for engaging the County Council Board of Health, but we do need to follow all of the processes to do that, with us being under an executive branch agency. And that as we see this turnover with the County Council and Board of Health, we want to make sure that they're informed of all of the previous efforts and that we can keep especially health in all policies moving forward. So also under goal 1, our second objective is by December 2025, train 50 residents or community leaders in health in all policies and health equity concepts, empowering them to speak to the Board of Health about their health equity priorities. So our strategies under this objective are by May 2024, collaborate with the University of Maryland Office of Public Health Practice and Community Engagement, Terrapin think tank to develop a health equity champions curriculum. By July, develop a pre and post program learner survey to measure the change in learner confidence in advocating for health in all policies to the Board of Health after completing the Health Equity Champion program. By December 2025, implement the pilot Health Equity Champions program to at least 50 residents and community leaders. And perhaps with our motivation, we can bump that timeline up a bit. And then by February 2026, develop a lessons learned report and improvement plan from the Health Equity Champions pilot. Moving on to goal 2. Our objective under goal 2, by December 2024, identify barriers and develop 5 solutions to the delivery of public health messages. So our strategies under this goal are by January 2024, initiate a collaborative partner presentation series at monthly Health Equity Workgroup meetings to identify barriers to the delivery of health messaging for the community they represent. By June, through engagement with the University of Maryland Center for Health Literacy, hi, Dr. Jackson, identify methods and tools to improve the accessibility and inclusivity of public health messaging. And then by December, utilize and disseminate evidence-based tools to improve health literacy at the individual, family, community, organization, and society levels. And then our second objective under this goal is to increase the number of community partners who inform and disseminate public health messaging in the community. So by July 2025, develop and implement a collaborative communications framework to synchronize communications in the community and increase opportunities to reach the focused population. So we really want to just this idea kind of built off of our coordination with the ad hoc vaccine working group through COVID response, and how we really need to expand our methods and our partnerships to get messages that are succinct, but also can reach a wide variety of our populations. We find that the government or social media is not always the best way to reach people. So we want to address those barriers to getting health messaging out to people that they trust and can use and actionable. With that, I want to first take an opportunity for anybody to have any reactions or feedback to any of these goals or objectives before we move on.
Just kind of going back to some of the expectations for 2024 and during our introductions. I just want to note that the timeline for the implementation of the pilot, as it stands, is by December 2025. But I do recall hearing that there was interest in piloting this year. Just want to make sure that we're comfortable with the original date, and if we want to move it up, what would we need to do realistically to make that happen, and is it realistic?
I think our timelines are absolutely flexible with what resources are available. I think that originally we selected the 2025 with the knowledge that we still need to define an implementation plan. But I think that if this is something that we want to prioritize and move forward, if we have the engagement, then we can make it happen. I think, yeah, I would love to see it move forward this year as well. So just to give everyone a very brief next steps, these goals will go into our community health improvement plan. And then we'll do an annual evaluation of that plan and kind of an update of where things lie. So if we end up moving faster, if we're getting through things faster, then we can make that update in the plan or in the annual report. And I think that maybe, oh, sorry, I was just going to say maybe at one of our upcoming meetings, we can discuss some of the very specific action steps and tactics to achieve these strategies, and that will help us define our timeline a bit better as well.
And I would also add that as we are reviewing the work plan and collaborating with the University of Maryland in order to move things along, if anyone is interested in being more engaged in how we're developing that, please reach out to Kimberly so that we can ensure that you are engaged in order to move things along.
Thank you. All right. Well, I know we have a great presentation coming up. So I wanted to introduce, probably needs no introduction, but Caitlin Murphy, the Chief of Public Health Innovation and Policy with the Prince George's County Health Department. The presentation today, while she's giving it, I just want everyone to think about those goals because this presentation aligns very nicely with both of our goals. But specifically when we're thinking of messaging, at our last meeting, we found that there's already existing knowledge around what people want to hear in their health messages. And Caitlin is here to talk about that today. So Caitlin, I will hand you the floor.
Awesome. Thanks, Kim. And hello, everybody. It is great to be here today to talk about Health Leap. Can you go to the next slide? All right, so this is our very formative research findings. So way back in 2021, we were awarded a grant from the Office of Minority Health within the Department of Health and Human Services for the federal government. And this was really to make sure that that health literacy was considered and health literacy interventions were implemented to help people be able to exercise their agency when it comes to COVID-19. So to be able to speak with their healthcare provider effectively around COVID-19, feel like their beliefs and values were listened to and respected, and that they were able to jointly make decisions regarding vaccination and regarding their health care overall. So that was the grant back in 2021 that we received. I'm going to talk today about the results of our formative research, which were a series of focus groups. And those were done by a partner of ours, SRB Communication, with a lot of help from the coalition, from different community partners that we have to try to recruit for these groups. So I want to thank anyone who was involved in that. And I would also be remiss if I did not shout out our great partners who are on the phone today. So of course, Jean Drummond and Liz Buchanan from HCDI, they have been, backbone in Health Leap in terms of project management and community health workers. Walter and his organization, I know Walter talked about how he had participated as a mini grantee in Health Leap, and he into our program. So definitely couldn't have done it without our mini grantee organization. So thank you, Walter and MLU. And then finally, of course, CASA. So Michelle LaRue is on from CASA. So thank y'all as well. They've been the other core partner in this work. So today I'll talk about our focus group findings. I know, as Kim said, that relates really closely, I think, to the goal that you all had. This is now a few years old, so I'm sure things have evolved a bit since then. But there are some overall trends that still apply and that we're seeing really good results, after tailoring our interventions around these results. All right, so the background, I mean, I think you guys know this. The reason that we did this work is because COVID-19 affected our community a lot. And we wanted to make sure that we weren't just assuming things about what different groups of individuals thought and wanted and valued in terms of COVID-19 and health literacy, but that we were actually doing the work to figure out why. So we put a significant investment into our focus groups. Can you go to the next slide, please? And please feel free to stop me at any time if you have questions. This is a lot of information, and we will send out the slides to you, so you'll have it all to look at. The final report for the focus groups is like 400 pages long. So I said, Kim, how long do you want this to be? I could talk for like 2 hours, or I could talk for 20 minutes. So there's plenty of information if you're interested in taking a deep dive. So our formative research spanned from July 2021 to January 2022. We really wanted to have a slightly shorter time frame, but there was some significant challenges recruiting from our populations. We definitely found that it was important to engage our community partners as much as possible to get folks into focus groups. So those were held via Zoom, 90 minutes, virtual focus groups. It was all secure. And we made sure that the moderators that we hired were from the groups that they were leading. So there was a sense of trust there. And then we held them in a variety of languages to make sure that cultural nuances were captured. So we held them in the language and then made sure when it was translated, we weren't losing anything. And then we also piloted our focus group tools once to make sure that they were, appropriate in terms of our recruitment screener and discussion guide, and got feedback from our different partner organizations. Definitely shout out to Dr. LaRue. I feel like maybe Dr. LaRue, you might even have led a focus group. I don't really remember if you were involved in the translation or just heavily involved with the building of the discussion guides, but either way, she was critical to this effort. So shout out to Dr. LaRue. Next slide, please. So our communities of focus, we had subpopulations. That's right. Yeah, CASA hosted the groups in Spanish and French. So our communities of focus, there was 18 focus groups, 9 populations, so 2 focus groups with each subpopulation. So we had middle and upper income African Americans, low income African Americans, French speaking African immigrants, English speaking African immigrants, Amharic speaking African immigrants, Creole speaking Haitian immigrants, non-documented immigrants, and Spanish speaking residents and ethnic seniors. Go to the next slide, please. Oh, did we skip one? No. Okay, so our discussion topics, we were really interested in hearing sort of the nuances around COVID-19. So what are your sentiments, experiences, and then the things that drive that? So culture, identity, intercultural perspectives and drivers, anything specifically related to vaccine status or hesitancy, and what the motivators and beliefs there might be, perceived community level stigma and racism, their experiences with patient-provider relationships, and their experiences with healthcare systems more broadly, and then social and trusted supports and health literacy needs. Go to the next slide. So this is our attendance summary. Roughly 9 people per group, somewhere a little bit more sparse, but overall pretty close to that. Go to the next slide. So there were some universal themes that came out that shaped our interventions broadly. So those would be that personal experience and personal stories that one might have heard contributed greatly to varying health decisions. Many people remained connected to their healthcare providers during COVID. So during the period for which almost everything was virtual and shut down, a lot of people did retain their connection to the healthcare system. There was some observed stigma associated with being a resident of Prince George's County, and as well as racial and ethnic groups. There was a lot of myths and misinformation about COVID-19 that were spreading through various channels. Experiences were similar in terms of changes to social and family lives and everyday activities. There was a lot of mixed feelings on news and information about COVID-19 and other health issues. And then there was unity in desired needs and wants from public health leadership. So we'll dig into some of this a little bit more in the next slides. Next slide, please. I'm going to skip over these. These are thematic analysis. Feel free to look at these yourselves. I'll just cut to the chase here. You can go to the next slide. So this was our group for middle and upper income African Americans. And again, I don't want to imply that when we survey 18 people, we can say definitively anything about one group or another group. This is, the research that we did to kind of better understand general trends, but certainly if we had surveyed, 150 people, it would be a lot better. So for middle and upper income African Americans, we saw a few things in terms of culture and identity and intercultural perspective. So a lot of folks reported preferring the term Black versus African American, and they were generally uneasy discussing racial topics around people who were not also Black. Vaccine motivators and beliefs, a lot of those were related to family, so wanting to see their children, wanting to see grandchildren and older family members, and then being required to do so by work or having some existing chronic conditions that may be exacerbated by getting COVID-19. And there's a feeling of initially some hesitancy, some wanting to see how things were going to play out, but then ultimately growing more supportive, and definitely a lot of COVID fatigue. Go to the next slide, please. So there was some perceived community level stigma and racism. So there was a feeling that there was some discrimination when it comes to the mask mandate, like perhaps it was enforced, more heavily with people who were Black or minorities. Evaluating risks, fears, and myths. There was some workplace risks, but the vaccine was viewed as definitely necessary. Booster guidance was unclear at the time of the focus groups, which was in September 2021. And then that mandating the vaccine in some places was not a bad thing, and they were ready to get back to normal. Go to the next slide, please. In terms of health information sourcing, there was a feeling that if a health decision was made, like they don't need any additional information on the matter. Like it was a decisive decision once made. Common sources included the traditional media, CDC, NPR, Dr. Fauci, good credible sources, public meetings, informal gatherings with family and friends who are in the medical field. Those were very important in terms of receiving healthcare information. And then in terms of interactions with the healthcare system, routine medical care was maintained during COVID-19. Access to health needs were continuously met. Providers were contacted if an issue couldn't be managed at home. And there was a desire for providers that share their specific cultural values and backgrounds. And electronic communication from providers was appreciated and effective, for example, through like a patient portal. Go to the next slide, please. In terms of, next, please, again, stop me if you have any questions. I'm happy to share further information as well, if that's helpful.
Caitlin, I did just have
Yes.
a very quick question. Thank you
Absolutely.
for the information so far. Age
Sure.
group in terms of the focus group participants. I noticed ethnic seniors, were they all in the senior age range, or were there other age groups?
Yeah, so good question. Let me pull that right now. So the first question was let me start with the seniors. So when we look at the seniors who were included, the age range for the senior group was over 55. So the first group was 55 to 73. The second group was 55 to 69. And the age ranges for the other groups, I can look at the one we just looked at, middle and upper income. I apologize. I don't see that right in this section. I would think that they cut off Dr. LaRue, do you remember the answer to that question? It's okay if you don't. This was a long time, but in COVID time, it feels like a long time ago.
Yes, I know the ones that we hosted were mostly people in the 30s and 40s.
Yeah, that's what I thought as well. I'm trying to see if there's a question. Yeah, so no kids. It says aim for a good mix of age groups. Terminate the screener if under 18.
Okay.
So yeah, I think in general, it sounds like they tended to be a little bit younger, but definitely that senior age group was 55 and over.
Thank you.
Sure. Good question. All right, so now low income African American focus group. Go to the next slide, please. So for culture, identity, and intercultural perspectives, there's a feeling that African roots run deep, so lineage and geographic residence of origin. And again, the term Black was preferred to African American Black is preferred and African American is used only if one is originally African. In terms of vaccine motivators and beliefs, not everyone was a believer in the vaccine. Despite their current status, a lot of people were very concerned about the impacts on their children. They did understand that the new normal that society is shifting towards, and some people believe that vaccines are a part of our everyday lives. But there's a lot of questions about what the true benefits of the vaccine are, and a belief that the community in general is not taking COVID quite as serious as they need to. Go to the next slide, please. In terms of perceived community level stigma and racism, there was deep fatigue at the thought of the future of COVID-19, severe negative impacts on mental health, and there was a stigma associated with living in PG County, as they affectionately called it. Evaluating risks, fears, and myths, many myths were identified, some were believed and others not so much. The next slide, please. In terms of health information sourcing, there was mixed feelings in terms of the trust level with traditional media, so CNN, MSNBC, NPR, but everyone seemed to trust Dr. Fauci, CDC, and the FDA. But there's also trust in like what was being shared on social media and then also medical websites. In terms of interactions with the healthcare system, deep distrust in the healthcare system and lots of uses of holistic and natural cures. Here's a quote: doctors are pushing the agenda of medication. And some individuals in the group did not have a primary care physician, and there's definite feeling that they were hoping to have more access to Black doctors. To the next slide. Great. For Spanish-speaking residents, in terms of culture, identity, and intercultural perspectives, Hispanic and Latino were the primary preferences in terms of identity. And the majority do interact with people outside of their race and find that culturally, family, food, music, and religion are the most important things in their lives. Vaccine motivators and beliefs. They wanted their vaccine status to not be public, so wanted to keep it confidential. They received really strong opinions about the vaccine from other people in their networks. Most were not super excited about it, but got vaccinated anyway. And many people believe that the vaccine mandates were an infringement of personal freedoms. Excuse me. Can you go to the next slide, please? In terms of perceived community level stigma and racism, there was judgment within the community. So there was some prejudice in public settings based on their race, an assumption that Hispanic people were at a higher risk for contracting COVID. In terms of risk, fears, and myths, the myths were tied a lot to natural and holistic practices, and a lot were spread on social media and amongst friends and WhatsApp. For health information sourcing, online resources like Google Scholar and CDC were very trusted. Advice was welcome from family and friends, but not from doctors. There's a general distrust towards news and the media. And one believes that their community is not one person believed that their community is not represented within the narrative about people of color and COVID-19. In terms of interactions with the healthcare system, there's a definite preference for home remedies versus seeing the doctor when ill. And a lot of people were not feeling heard or taken seriously when they were at the doctor. Routine visits still occurred, but the relationship really did not extend beyond that. All right, next is non-documented immigrant focus groups. So in terms of culture and identity, deeply rooted pride in where they came from and what they value. Always first identify with their culture, their country of origin and cultural heritage. Religion and faith were very important, and self-identify as hardworking, resilient, and active in their community. For vaccine motivators and beliefs, excuse me, for vaccine motivators and beliefs, the ability to protect their families was a very strong motivator, and they shared accounts of people that they knew who were very sick or who almost died from COVID or who did die. The majority believed in the validity and effectiveness of the vaccine, and several people were very fearful of getting COVID-19 and dying if they were not to have the vaccine. Move to the next slide, please. In terms of community level stigma and racism, people look down, there's a feeling that people look down on their community and treat them like they're less than because of language barriers. And a bit of stigma still exists in some Hispanic communities, especially when it comes to different dialects of Spanish. Evaluating the risks, fears, and myths, there was some distress that some of the myths originated within the church. There was news was often seen as misleading, which was harmful. Communities sometimes turn to less credible sources, and they have trouble letting go of false beliefs. Sorry, I have a tickle in my throat. In terms of health information sourcing, this is a quote, "You can't believe everything you see on social media." A lot of individuals were turning to home remedies as their only option, and their community is heavily relied on as a resource for information. And if you noted that the Prince George's County Facebook page and website were helpful, which we love to hear. Interactions with the healthcare system, there is emphasis on not having healthcare and having difficulty paying for medical bills. Community clinics were extremely overloaded during the pandemic. And a quote here, "Healthcare in the US lacks humanity and personal touch." Go to the next slide, please. All right, so for our seniors focus group, all of the people in our senior groups were Black or African American. The term that they chose depended on a number of factors. There's a feeling that this is a quote, "Black is an identity." There were several reflective connections to the meaning of Blackness. Vaccine motivators and beliefs, the majority there were vaccinated and boosted. Initially, there was some hesitation, but there's societal pressures sort of driving the more reluctant people. Several people were against the idea of something foreign going into the body, and but the lives of seniors felt extremely limited without the vaccine. In terms of community level stigma and racism, the media refers to Black populations as a monolith when speaking of COVID-19 risk. And there was a feeling that less collective empathy was provided to Black people. This is a quote, Black people have been criticized for not following prevention guidance and for not listening to science. In terms of risks, fears, and myths, participants experienced and observed health inequity most when it came to accessibility for the COVID vaccine. And many myths were identified. Some were believed at first, and others were tested and confirmed not to be true. In terms of where they get their health information, there is a feeling that it is generally accessed online, or they will reach out to their adult children who might work in the medical profession, and that sole advice from one medical provider could not be fully trusted. There's a lot of independent research and fact checks that were taking place online. In terms of interactions with the healthcare system, constant communication with healthcare providers during COVID. They were very loyal to their providers and preferred to only visit the same provider. Holistic practices were also inquired about actually with their doctors. And then delaying healthcare procedures due to COVID-19 or the fear of COVID-19 was common. All right, for French-speaking African immigrants, in terms of culture and identity, identity was associated with the country of origin. There is pride. Pride in their culture was the foundation of who they are, no matter how long they've been in the United States. And holistic practices were the most common in this group. In terms of motivators and beliefs, there was mixed opinions on the vaccine, an intense fear of death, and definitely feeling that all wanted to do everything they could to stop the spread, and some feeling like they might be genetically immune from contracting COVID. Terms of perceived community level stigma, other ethnicities initially believed that people of color were immune, and the media contributes to the population panic, a feeling that race should not matter when trying to obtain something health related. For risk, fears, and myths, many people heard that their African genes would protect them. And this is a quote, Black people are more likely to contract it because they are obese, dirty, and negligent, unquote. For interactions with the healthcare system, there's extremely high levels of distrust in the media and the public health system. And some people do not engage with the system and would rather incorporate holistic and natural remedies. The language barriers and healthcare costs were significant barriers for this group. A lot of people felt like there was a lack of attention and urgency when seeking treatment, and overall just no feeling of support by the healthcare system, from the healthcare system. Go to the next slide. For the English-speaking African immigrants focus group, the term African was the more popular term. Several noted that they do not identify as Black. Respectful and firmly adhering to African cultural roots. The word tradition meant a lot, and there were strong religious feelings in this group, and always a shared sense of community. In terms of vaccine motivators and beliefs, the deciding factors to get the vaccine were rooted in fear and force. Many of these emotions were developed from online information consumption. And while many got vaccinated, they felt there was still a lot that was sort of unknown with the booster. For risk, fears, and myths, there was a lot of myths and misinformation that stemmed from kind of rumors and some spiritual beliefs. Contrary to traditional reliance on holistic remedies for diseases, they believe that people in the US take a pill for everything. And participants contributed to the efforts to stop the spread of false information. For interactions with the healthcare system, there's mixed opinions on healthcare practices, and some engage the healthcare system only when necessary. For the Creole-speaking Haitian immigrant focus groups, in terms of culture and identity, Haitian culture is vibrant, the people are resilient, and spirituality is important. And there's a feeling that language was a key element, and dialects can include a mix of English, Creole, and French. For vaccine motivators and beliefs, protecting families was top of mind, and the next common reason was to return to socializing in public with others. Healthcare professionals have seen the benefits firsthand, and people who were not vaccinated do not feel that it has been tested enough. In terms of community level stigma, some in the US felt that Haitian people lacked access to resources about COVID-19 and the vaccine, and a feeling that people wrongfully blame outsiders or immigrants for bringing things into the country. For risks, fears, and myths, there's misinformation about the vaccine in both sessions, and there's a mention of being excluded from the Black Lives Matter movement and ongoing social justice initiatives in the US. For interactions with the healthcare system, a lot of people said they would go to the doctor or hospital if they were sick, but that's not their first line of defense. And they inundate their doctors with questions because they're very skeptical. Honesty is appreciated even when the primary care doctor does not know the answer. And for the Amharic speaking residents, I think, is this the last? I'm not sure. This might be the last one. The Amharic speaking residents, for culture and identity, there was diverse views on personal identity, but definitely notably proud of culture, food, and remedies. A feeling that the culture can be closed off at times, which evokes negative perceptions within the community. In terms of vaccine motivators and beliefs, there's a desire to remain safe for loved ones, a strong desire to get back to normal life, and a feeling that there's a lot missed out on in terms of living during COVID-19. For community level stigma and racism, there is no direct stigma experience, but they observed it with other communities. And there was misguidance and miscommunication in the way that health education information was distributed. For risks, fears, and myths, there was misinformation about the vaccine, but a lot of people just disregarded them and did not believe in them. In terms of interactions with the healthcare system, there's a high level of trust in science, but not enough to access, but a feeling that there was not enough access to healthcare providers, that it was very hard to get appointments with medical providers, and that overbooking has made them miss their opportunities to schedule frequent visits, and that they work to boost their immune system and tend to lean towards holistic solutions first before reaching out to the doctor. All right, so that concludes the sort of overall findings of the groups. I know that was a lot, so please feel free to review the slides and ask me any questions that you might have. The last section here is just the section that was focused on what the needs are from public health leadership. So I feel like this is the part that might be actionable for us. So universal county needs, so in all of the groups, we found that there is a need for better access to healthcare and better connection to the community. And some communities needed this more critically than others. A general desire to see their leaders out in the community spearheading the health initiatives, especially related to COVID-19. A breakdown of data based on subgroups within ethnic communities instead of lumping everything together. A desire for communication to be honest, transparent, clear, and timely, and for information to be made easier to access and easy to understand, and also to acknowledge and be more sensitive to the mental health effects of the pandemic. For each group specifically in this area for Amharic speaking residents, there was a need for more access to vaccine centers, kits, and other resources and information. For Creole speaking Haitian immigrants, the finding was that Haitians might be more receptive to information if the government did more to reach their community directly, and that information should be printed in Creole or set up a Creole speaking hotline, and then reach them where they are. So go to churches and local restaurants and consider doing vaccination sites there as well. Slide, please. For the English-speaking African immigrants, of feeling that there was a need for reassurance in the accuracy of the information that was being shared, and then a need for comfort and support within the community. For French-speaking African immigrants, there's a feeling that there is a need to repair the years of damage and fear that have plagued this community, and to counter false information with the truth and better educate the community. Slide, please. For low-income African Americans, feeling that there needed to be more organized release of information and more leadership from politicians and public health officials on the front line and in the community, and more efforts to dispel myths to clear up confusion. And for middle and upper income African Americans, a need for greater access to health information, better segmentation and diversity outreach, so feeling that generic messages don't resonate, and a desire for the community to be engaged to help advocate and share information. For non-documented immigrants, they're interested in us listening more, so doing things more things like these focus groups and equipping leaders with data to help convince the community to believe in the truth. Working with churches and religious leaders to help dispel myths and promote the vaccine, and holding free events and mandating proof of vaccines, since this community enjoys gatherings. For Spanish-speaking residents, a desire for more tailored outreach, hiring Hispanic or Latino leaders to go out in the community, setting up a hotline for people to call and ask questions about the vaccine, and to host community outreach events where people can ask questions and speak directly to health officials. For ethnic seniors, there was a feeling that knowledge is power, so a desire to continue to receive information from public health leadership and to equip them with information to better help others. So they're not afraid of dying and want to ensure that others can avoid this for as long as possible. Leadership needs to be proactive, not reactive, and encourage public health leaders to collaborate with private practices and community centers. All right, so with all that information, which acknowledges a lot, we went back and tried to develop some interventions to address these things. So this is where Liz and Dr. LaRue played critical roles. We were able to put together a bunch of materials and interventions around health literacy in general, COVID health literacy, patient rights and responsibilities. So really kind of one trend that we heard throughout that was that people were having a hard time either accessing medical care or feeling like the medical care was appropriate or helpful to them or available. And so we wanted to help folks, know what to do when they see a doctor or primary care provider, make sure they're prepared for their visit, what their rights are at their visit, what to do and say, what to do after the visit, and then more broadly, overcoming the social determinants of health. And I will also say this grant involved a provider side intervention also. So we also worked with FQHCs and other providers to train physicians in health literacy broadly and COVID literacy, and kind of sharing the findings that we had and helping them be able to improve on their end as well. Next slide, please. And our teams of community health workers who were recruited from the communities we had the focus groups with, because we heard that was important. They were able to assist with conducting outreach in the neighborhoods with the lowest COVID vaccination rates, conducting social determinants of health assessments, distributing the handouts and delivering facts about virus transmission, prevention, testing, and vaccination, and then how to talk to providers about COVID-19 and about your health in general. And then actually offered coaching sessions with residents on how to use this information, and offered referrals and navigation assistance to access primary care, social determinant of health information, and COVID-19 testing and vaccination services. I'm sort of breezing through this part because I think what you guys really wanted to hear was the focus group results. But I got to share the results because I'm proud of them, which is that as of October 2023, which is the last time we analyzed the data, it's quarterly, 14,812 residents were reached with COVID-19 health literacy information. 4,134 residents received an actual health literacy coaching session. 90% of those individuals were racial and ethnic minorities. And then after the coaching sessions, 85% of people felt more confident asking their providers what they needed to know about COVID-19, requesting interpreter services, and navigating the health and social service system. So we saw consistent and sustained improvements in that patient-provider interaction. And that's all I have for you. So I know that was a lot, but please feel free to ask any questions. And the dynamic team of me, Liz, and Dr. LaRue will answer them as best we can. Thank you for having me.
This was tremendous work. Thank you so much for presenting this, Caitlin, and for all those that were involved. I have so many questions, and I can only imagine how many questions you all had to go through, and much work to put this together. I mean, I'm trying to think of some of the tie-ins to the work that we're doing with the Health Equity Champions work. I noticed at the health sourcing, there's some surprising results. Were they given options, or were they kind of saying, this is where we get our information? Because I noticed for one of the groups, Google Scholar came up, which to me floored me because there are some health professionals who I don't think, would naturally go to I haven't used Google Scholar in a long time, so it was interesting. So I was just wondering how those answers came up. Were they given options, or was that just literally something that they were doing on their own?
I will tell you exactly the answer to that question. So
and Michelle says they were open-ended questions. So
they were open-ended questions. So we had myths, we had patient provider engagement. Oh, okay. So we've reached the last section of the night. Let's talk about where you obtain trusted information. By a show of hands, have you ever sought after any information on COVID-19 transmission, the vaccine, or any other related topic? And then who are you likely to turn to when seeking to understand COVID information? Who or what you trust most and why? How have these sources shaped your knowledge about COVID-19 prevention in your community? So very open-ended.
That's helpful. I mean, that kind of shifts my thinking about what the community like a lay resident in the community may be using for their sources. Does anybody else have any questions for Caitlin or the rest of the team? I know I have additional questions, but I don't want to dominate.
I wanted to share. Go ahead, Sharon.
I was just gonna say, I had a question about education level, whether that information was gathered, because I believe that there's often a significant correlation in terms of answers depending on people's educational levels, maybe more so than income levels even.
Yeah, I think that so The answer is yes, it was collected. Do I know off the top of my head what the impact of it was? No. Yeah, Dr. LaRue.
No, I think that's a great great question, Sharon. And I agree. I think that makes a huge impact. I do think it was on the questionnaire, but it was done after the fact. People weren't stratified into groups based on that. And I think that would be an interesting way of doing these focus groups in the future.
Well, it'd be interesting to even take the data that you have and maybe do an analysis of sort of the number of people who, what levels of information were achieved across, people had achieved across the group. So it gives you sort of a sense of where folks might be coming from.
Yeah, this is interesting. So for the middle and upper income, there was like it's completely down the middle. Like there's 2 people in each category for some undergraduate, completed undergraduate, some professional graduate, or completed professional graduate. So it seems to kind of vary. I was thinking it would correlate a little bit more. So yeah, great point.
Caitlin, well, thank you very much for this great presentation. It was very comprehensive. It was a big, major effort. And my question is, what would be the 1 or 2 lessons learned from this qualitative research that you guys have conducted? I can see that this is not an easy question, maybe because we have seen such a diversity of perspectives that it may be difficult to eventually summarize, not necessarily summarize, but get 1, 2, or 3 kind of unified lessons learned for the future of improving COVID-19 prevention programs. Could you identify 1 or 2?
I would think that, I mean, to me, one big takeaway, and this might be my own sort of personal bias, but I feel like I've heard the standard of practice, I feel, with health literacy when it comes to myths and misinformation is to never repeat it. Like, just put out the correct information, but don't address the misinformation. And that's like the opposite of what we heard in these groups. And when we went out into the community, they actually responded really well to our, they wanted that. They wanted not only to hear the myth and then the actual facts, but they wanted to be able to carry that information to their community so that they would be able to dispel the myth actively when they heard it. And so that was a major takeaway to me, that I was kind of, it's the opposite of what I feel like the sort of like best practice knowledge is, but it seemed to have a really positive impact. And then I guess, well, let me ask Dr. LaRue, did you have another one, that you felt was kind of a big takeaway?
Yeah, no, I think trusted messengers in the ones that we talked about also varied quite a bit. I think the less people relied on like traditional media to gain their information, it was about trusted messengers. And many of the groups that we talked to it wasn't always like Fauci or the governor. They may not even recognize who those are. It was more like they're more within their network. So maybe their reverend, maybe their neighbor. The matriarch of the family was found to be the grandmother is very influential within the family unit, at least in the Latino community. And so that was a huge takeaway for us. I'll add one more that's not in the report, just my own anecdotal, was that with so much interconnectivity now with WhatsApps and other platforms, we were fighting myths at a global scale. A lot of people were getting like, oh, well, a friend of mine in Spain forwarded me this video or this meme or this text, or family from Guatemala was sending me things, be like, hey, is this true? And so I think, what we were up against this time around versus other public health emergencies was that scale of fighting the misinformation. The one other takeaway for me that just really, really stuck with me, a comment from the undocumented focus group was, while yes, they embrace natural medicine quite a bit, but there was a large sentiment also that we are pushed to rely on natural medicine due to barriers of access to care. And that really has really stuck with me, and I think it's pertinent to our mission and in our conversation today. So I share that as well.
Excellent. Thank you very much.
I definitely also found, so as a sort of response to this, we launched like a small thing with some University of Maryland students to go do conversations in church after Sunday service with the pastor and Dr. Carter. And what we saw there was like, I think to Dr. LaRue, to your point of like a trusted messenger, it was very interesting to see not only Dr. Carter, but also the pastor, because the pastor was able to, I mean, a lot of these pastors, like during their sermon, they were like, God gave us scientists who gave us vaccine, they were kind of weaving weaving the scripture into, like loving others, and loving others means protecting others, and they were able to kind of hit those spiritual messages. And then Dr. Carter with the scientific messages, but the questions that were asked in those were very interesting. Like, we had one woman ask, like, she's like, I don't believe this, but I keep having these young people telling me that the vaccine is the mark of the devil. And like, what do I tell them about that? And the pastor was able to respond like, well, if you're looking for the mark of the devil, you're going to find it. Like, people will say that barcodes are the mark of the devil, or, is that what you're looking for? You want to look for it, and kind of went into like a more spiritual answer. And then Dr. Carter with the scientific answer. So I think there's like a lot of, I think that was one of the things that came out of for the overall messages, just like for health officials and, those higher up people to be more accessible and like around to answer those questions, I feel like was very powerful to witness in that setting. And then partnering with, the faith community. So yeah, I think overall, I was honestly astounded when I saw the first set of data. I mean, I knew we were doing good work, but I couldn't believe how well this was working. So I think it's really promising in terms of a good approach for addressing health literacy. I see, Rhonda, you had a question. Can you, so when you're saying disinformation, and like maybe this is ignorant of me, but you're asking about like people intentionally trying to deceive or something like that, if that came up?
Oh, I'm sorry. No, my question was really meant for whether folks felt that sometimes the information was intentionally done to misinform. And I know that we experienced a lot of that with younger groups. And I was just wondering whether any of the groups had expressed, whether some of this misinformation or disinformation was intentional.
So I definitely think that from reading the results, and I'll let Dr. LaRue answer from being there. But I saw that there was a definite like feeling of mainstream media being manipulative one way or another, or having an agenda. And so a lot of like mainstream news channels or sources like that were not seen as trustworthy because of like spin. So not necessarily like disinformation level, but more like what is your agenda behind sharing this information? Dr. Lear, did you have anything to add?
Yeah, I think you make a good point, Caitlin. A lot of community members talked about the media being like sensationalistic, doomsday kind of tone to all of their reporting. And so that just made it feel like the report itself, the TV segment or whatever it was very slanted. And so that they didn't feel like they could really trust the information. Like, is it really as bad as they say? But in sharing of information within individual community members, I didn't hear a tone of I'm purposely misinforming my neighbor. It was more around that like media platforms, and people were just sharing out of concern or out of their own personal beliefs. But definitely that sensationalism from mainstream media was not received well from the community. And they felt that so much of the segments that were out there were too short. They weren't informative. I know like the interviews that I've done, they're like, 30 seconds is like a marathon for them. And so it's really hard to be able to really give the information you need to the community in such short sound bites.
Yeah, I just think that yeah, I think there was something with NIH where they were interviewing providers and
Oh, Rhonda, I think you
I'm
went.
sorry, the
Oh, yeah.
providers were concerned during the COVID about the intentionality, of disinformation, and they felt that that was a real force for them trying to provide education when there was an element of disinformation that was countering them. And I just wanted to get a feel for whether, the participants actually felt that in any way. But that's good. That's very insightful. Thank you.
And I wonder if that was a report from physicians, it would also be interesting to know if like it wasn't working, them countering it because they weren't the person who was going to convince that person. Like we didn't see across all the groups, there was no consistency about whether their doctor was the trusted source of health information. Like sometimes it was, the aunt who's a nurse or, whatever, or doing their own independent research. And there was like some groups had really seemed to have really close ties and good access to healthcare providers, and others not so much. So yeah, I think it definitely physicians were up against a lot, but it would be interesting to know if like maybe it was falling flat because it wasn't them that was going to deliver the message that would change the mind.
Christine, did you have your hand up?
I did, and I'm looking at the time, and I have like 3 different questions, and I don't. I mean, I'm trying to decide which question is most salient. So I mean, so every time somebody talked, I would come up with a new question. So Dr. LaRue, you were talking about sound bites, and sometimes those weren't enough to provide information. And I saw that in the results, in some of the materials that were created for the intervention, it looked like mostly print. Were there a variety of different formats, and were there any that resonated more with the community or with certain like certain groups? Seeing that messaging and public health messaging and communication is part of one of our goals for the work group. I'm just curious about what's worked and for who, like the format.
I can tell you there was a good amount of print materials that were distributed. I know we use them a lot within our CHW team as reinforcement or deeper information. We never, I always tell the team, like, just handing them a flyer, that's not engagement. We really use it more as something to take home, to process, to remember what we've discussed together, whether it's on a street corner, at a laundromat, at a community event, whatever the setting is, but this is a way for them to be able to take that information in hand, share it with others, as well as have it to further digest. We do a lot of that. I know there's been a lot of messaging put out around COVID digitally as well. There are a lot of PSAs done and other things. I know Caitlin produced a great PSA with some of the CHWs on the team also. And so, but I know, like, boots on the ground, what we mostly do is conversations, and then use the print materials as backup.
Yeah, that's helpful.
And Liz, is that the same thing that your CHWs are doing? You know, I couldn't let you get away without.
I know. Yeah.
Okay, awesome. And Walter, how about your folks who are, I know you're doing the initial outreach. Are you handing anything out, or not to put you on the spot?
Yeah.
If you don't know.
No, it's okay. Yes, no, I was wondering whether the messenger have become even more important than the message itself. So it seems that in our Latino community, this is certainly a fact. You know, who told you that? That is, you say something about the vaccine, and then the next question is, who told you that? So the person or the source of the message kind of validate the content of the message. But today I have seen that that's not particular to the Latino community. It seems that many people with a variety of ethnic backgrounds share this same trust in the messenger, uh, which is becoming more important again than the message itself. Uh, well, that's just a question. That's something in my mind. And the second topic about the Latino community and our experience reaching out to them with COVID-19 messages through community health workers. That was actually definitely the most effective way to reach them out through community health workers. Much more than via media. And and what we learned is that well, people trust uh, people who look like them. So people trust CHWs because they are people from the neighborhood. They trust them. That is one thing, and the other is that there is a an structural, let's say, gap between the low income community and the health system. So this gap, due to social determinants of health, is not always easy to bridge. Uh, so the community health workers act as bridges between the community and the health system. And at the very beginning of the pandemic, Latinos were the group that had the least vaccination rates related to COVID-19. But after all these interventions, the Latinos in Maryland became the group with the highest vaccination rate, which was very surprising.
Absolutely. I feel like when way back when Kim and I were organizing clinics, I felt like we were at the point where we were kind of, there was a feeling that, okay, we're organizing clinics and we really have to work on promoting and getting, people in and fighting that hesitancy. And we were seeing low numbers in our main sort of sports and learning complex and all that. But then we like would do it at an apartment building where most of the people spoke Spanish, and it was like the longest line. And I was like, oh my God, like we haven't even solved the access issue in this community. Like we're still there. And so I think when that happened, to your point, yeah, then there was like, then it became quickly just not kind of the same. It was interesting. I don't know what point I'm trying to make, but yes, I agree with what you said. Thank you for that.
Oh, just to add one more sentence, is that through these programs like the ones the Prince George's County Department of Health is implementing, has been implemented during all this time. I mean, these programs work, and that's encouraging. It is very encouraging to see that you see your community going from, let's say, from almost zero vaccinated people to the highest rate. And what happens in between? What happened was this kind of health equity programs that are really effective.
Thank you so much. Well, with that, sorry, I don't want to take over. I know I should have known we had some discussion questions ready just in case there wasn't a lot going on or if everyone was quiet, but we obviously didn't need them. But I do want everyone just to continue to think about the specific barriers that were identified through these focus groups. I know I certainly was listing them down as Caitlin was talking today, but I think we can utilize those as we start thinking of our next steps to address our goals and strategies. So just to keep us on time, Xerxes, if it's okay, I can jump into some of the community announcements. And Christine.
Yeah, go ahead. Mm-hmm.
So just wanted to share with everyone that Maryland Medicaid has now expanded gender affirming healthcare services. Maryland Medicaid covers medically needed care that upholds the safety, dignity, and respect of transgender and gender expansive people. So this is relevant for our health equity group because we know that access to care and care for all is very important. And it's nice to see these changes happening so that everyone can get the care that they need. So we will send these slides out. There's links for additional information if you want to look into that. Also, we wanted to share this internal health department event coming up, the Prince George's County Status Neutral Summit, which is focused on highlighting person-first strategies to diagnose, treat, prevent, and respond to HIV. So we encourage everyone that's interested to register for that event. And we'll send that information out as well with the notes. So you can register. It's on January 31st, so coming up soon. And then next we have an event, the Empowered to Serve Maryland Black Farmers Business Accelerator Finale. This is taking place in Baltimore, but it does have finalists from Prince George's County. So we want to continue to promote all of our residents and who are working hard to boost the health of Prince Georgians. Did anyone else have any community announcements they wanted to share? And if you don't have any to think of right now, feel free to send them out to me and I can get them in with the notes tomorrow. I will pass it to our co-chairs to close this out.
So thank you so much, Kim. Thank you very much, Caitlin and Dr. LaRue. Very insightful, very informative information. You can definitely see how a lot of the information that you presented also aligns with the work that we're currently doing and the work that we are looking forward to doing in the future. And would love to take some of the information that you presented and apply that to what we're doing. So if you have any questions, please feel free to reach out to Caitlin and Dr. LaRue. Is that a thumbs up? Is that okay? Okay, perfect. Okay. And we will look forward to seeing you next month. Our next meeting is February 15th at 3 p.m. Between then, we'll definitely send you the information pertaining to this very robust meeting that we had today. So thank you.
Have a
Have a great
wonderful
evening.
afternoon.
Bye-bye.
Thanks, everybody.